the worst fetus killers in the months of pregnancy. 1 factor V Leiden. 2 methylene tetrahydrofolate reductase, MTHFR, deficiency. 1 factor V Leiden, RS6025 or F5P.R506Q. Is a variant, mutated form, of human factor V, one of several substances that helps blood clot, which causes an increase in blood clotting, hypercoagulability. Due to this mutation, protein C, an anticoagulant protein which normally inhibits the pro-clotting activity of factor V, is not able to bind normally to factor V, leading to a hypercoagulable state, i.e., an increased tendency for the patient to form abnormal and potentially harmful blood clots. Factor V Leiden is the most common hereditary hypercoagulability, prone to clotting, disorder amongst ethnic Europeans. It is named after the Dutch city Leiden, where it was first identified in 1994 by Professor Arbertina under the direction of, and in the laboratory of, Professor P. Reitsma. Despite the increased risk of VTE, people with one copy of this gene have not been found to have shorter lives than the general population. The impact of the factor V Leiden mutation on pregnancy. A resistance to the anticoagulant activity of activated protein C, APC, most frequently due to a point mutation in the factor V gene. The Leiden mutation represents the most common genetic cause of thrombophilia. The Leiden mutation has been significantly related to pregnancy complications associated with hypercoagulation. 1 deep vein thrombosis during pregnancy, 8-fold increased risk. 2 preeclampsia, prevalence of the mutation up to 26%. 3 placental infarction extending to 10% of the placenta, 10-fold increased risk. 4 abruptio placentae, prevalence of the mutation up to 29.6%. 5 second and third trimester pregnancy failure, prevalence of the mutation up to 31.3%. An association of the maternal mutation with recurrent first trimester miscarriage does not emerge from the literature, although fetal mutation, frequency higher than twice compared with that of the general population, has been related to early spontaneous miscarriage. Although some evidence suggests an association between APC resistance and intrauterine growth retardation, no significant relationship emerges currently from the literature. Screening for the Leiden mutation would seem advisable in women with previous pregnancy complications amongst those associated with APC resistance. Carriers of the mutation should be given appropriate counseling. The screening of asymptomatic women is not recommended at present. Diagnosis. Suspicion of factor V Leiden being the cause for any thrombotic event should be considered in any Caucasian patient below the age of 45, or in any person with a family history of venous thrombosis. There are a few different methods by which this condition can be diagnosed. Most laboratories screen at-risk patients with either a snake venom, e.g. dilute Russell's viper venom time, based test or an APTT-based test. In both methods, the time it takes for blood to clot is decreased in the presence of the factor V Leiden mutation. This is done by running 2 tests simultaneously. One test is run in the presence of activated protein C, APC, and the other, in the absence. A ratio is determined based on the 2 tests and the results signify to the laboratory whether APC is working or not. There is also a genetic test that can be done for this disorder. The mutation, a 1691GA substitution, removes a cleavage site of the restriction endonuclease MNLI, so PCR, treatment with MNLI, and then DNA electrophoresis will give a diagnosis. Other PCR-based assays such as IPLEX can also identify zygosity and frequency of the variant. Management. As there is no cure yet, treatment is focused on prevention of thrombotic complications. Anticoagulants are not routinely recommended for people with factor V Leiden, unless there are additional risk factors present, but are given when such an event occurs. A single occurrence of deep vein thrombosis or pulmonary embolism in people with factor V Leiden warrants temporary anticoagulant treatment, but generally not lifelong treatment. In addition, temporary
a complex biochemical process that regulates gene expression, that is, turning genes on and off. It also governs intracellular detoxification, regulates protein function and RNA production, and supports the immune system. MTHFR metabolizes folate, which is a key nutrient for methylation, specifically the conversion of homocysteine, a potentially toxic amino acid, to methionine. MTHFR provides methylation with its main fuel, folate, 5-methyl tetrahydrofolate. Without adequate amounts of folate, methylation function is reduced. Methylation is required for virtually every process in our body, therefore affecting numerous health conditions. In fact, in many studies, researchers have found that MTHFR is linked to a variety of conditions. Below is a partial list in alphabetical order: addictions, Alzheimer's, anxiety, asthma, autism, atherosclerosis, bladder cancer, bipolar, blood clots, breast cancer, chronic fatigue, chemical sensitivity, depression, diabetes, Down syndrome, fibromyalgia, glaucoma, gastric cancer, heart disease, heart murmurs, heart attack, hypertension, IBS, infertility, mental illness, migraines, miscarriages, multiple sclerosis, neurologic diseases, Parkinson's, preeclampsia, prostate cancer, pulmonary embolism, rectal cancer, schizophrenia, spina bifida, stroke, vascular dementia, and many more. Why do we need this test? Over 80% of the population has a mutation in at least one of the two most important alleles, C677T and A1298C, of the MTHFR gene. MTHFR C677T can also lead to high homocysteine, although this can be difficult to clinically identify because other factors can also influence homocysteine levels. Research has shown that mutations of this allele have a greater impact on health compared to other alleles. MTHFR A1298C has not been found clinically to have an effect on homocysteine levels. This allele has a greater effect in the production of BH4 tetrahydrofolate. BH4 is a cofactor in the production of neurotransmitters such as epinephrine, norepinephrine, serotonin, dopamine, and melatonin. A deficiency of BH4 may affect the cardiovascular and neurological systems as well as emotional well-being. Compound heterozygous and homozygous C677T are considered severe or at risk of reduced methylation. High homocysteine has a high risk factor for numerous diseases. Homozygous C677T and compound heterozygous MTHFR mutations are more likely to correlate with elevated homocysteine levels and a greater risk of heart disease. Those with a heterozygous mutation of the MTHFR gene C677T may lose roughly 40% of their enzyme activity, and those with a homozygous mutation may lose up to 70%. Today, science has proven that our body has a mechanism capable of silencing bad genes or regulating gene expression. This process is called methylation. MTHFR and detoxification. Our bodies are constantly detoxifying from pollution and toxicity in our food, water, and medications. A complete detox program must include proper methylation. Without knowing whether you have a mutation or which mutation you have, it is very hard to estimate your needs for proper methylation. MTHFR and weight loss. The body engulfs toxins and fat cells to protect us. As long as there are toxins in the body, there will be a higher need to produce fat cells. Every weight loss program should include a detoxification phase that ensures the recipient has adequate levels of folate by testing for MTHFR mutations and serum folate levels according to the recipient's genetic code, and supplement with the appropriate amounts of methylfolate if needed. MTHFR and thyroid. Thyroid hormones are activated in the nucleus of cells. Methylation is one of the necessary components of thyroid hormone activation. Even if all of the thyroid markers are within range, methylation is needed to activate the hormones. If all the markers are normal but you still have symptoms, it is very possible you have a methylation problem. MTHFR, and gene expression. With the exception of a few diseases like sickle cell anemia and cystic fibrosis, most diseases are controlled by a set of genes, including chronic diseases like most cancers, cardiovascular disease, mental illness, and diabetes.
Treatment with an anticoagulant such as heparin may be required during periods of particularly high risk of thrombosis, such as major surgery. Organ meats, nuts, beans, nutritional yeast, and raw/fermented dairy products. 2-methylene tetrahydrofolate reductase, MTHFR, deficiency. MTHFR mutations and recurrent miscarriages. Increasing focus has been placed on something called the MTHFR genetic mutation and its associations with a host of abnormal health conditions, some of which are strongly supported and others of which are speculative at best. In recent years, a handful of scientists have suggested that the mutation could very well explain why certain women have recurrent miscarriages. While the theory is far from conclusive, it does bring into the spotlight the role that genetics may play in unexplained miscarriages, if only in part. Causes. MTHFR is the rate-limiting enzyme in the methyl cycle, which includes the conversion of homocysteine into methionine. Defects in variants of MTHFR can therefore lead to hyperhomocysteinemia. There are two common variants of MTHFR deficiency. In the more significant of the two, the individual is homologous for the 677T polymorphism. This variant in particular is the most common genetic cause of hyperhomocysteinemia. The resulting enzyme is thermolabile and in homozygotes, enzymatic activity is depressed to 35% of its usual level. The second variant is a milder one, caused by a homologous 1298C polymorphism. This leads to 68% of the control values of enzyme activity, and it normally does not lead to low serum folate. Explaining the MTHFR mutation. MTHFR and miscarriage risk. Characteristics. Methylene tetrahydrofolate reductase, MTHFR, deficiency is the most common genetic cause of elevated levels of homocysteine in the plasma, hyperhomocysteinemia. The MTHFR enzyme plays an important role in processing amino acids, specifically, the conversion of homocysteine to methionine. Genetic variations in the MTHFR gene can lead to impaired function or inactivation of this enzyme, which results in mildly elevated levels of homocysteine, especially in individuals who are also deficient in folate. In these individuals, a daily supplement of low-dose folic acid may reduce and often normalize their homocysteine levels, but this has not been demonstrated to improve health outcomes. A common genetic variant in the MTHFR gene is a 677CT polymorphism, NM_0059557.4C.665CT, RS1801133. This variant encodes a thermolabile enzyme that is less active at higher temperatures. Individuals who carry two copies of this variant, TT homozygous, tend to have higher homocysteine levels and lower serum folate levels compared to controls. More than 25% of Hispanics and around 10 to 15% of North America Caucasians are estimated to be homozygous for the thermolabile variant, TT genotype. The TT genotype is least common in individuals of African descent, 6%. Another common MTHFR variant, 1298AC, NM_0059557.4C.1286AC, RS1801131, does not cause increased homocysteine levels in heterozygous or homozygous individuals, but combined heterozygosity of 1298AC and 677CT results in an outcome similar to TT homozygous individuals. Until recently, it was thought that MTHFR deficiency, by causing elevated homocysteine levels, led to an increased risk of venous thrombosis, coronary heart disease, and recurrent pregnancy loss. However, more recent analysis has not found an association between elevated homocysteine levels and the risk of venous thrombosis or the risk of coronary heart disease. MTHFR polymorphism genotyping should not be ordered as part of the clinical evaluation for thrombophilia, recurrent pregnancy loss, or for at-risk family members. Rarely, more severe variants in the MTHFR gene can be a cause of an autosomal recessive inborn error or metabolism where extremely high levels of homocysteine accumulate in the urine and plasma. This can cause developmental delay, eye disorders, thrombosis, and osteoporosis. But more commonly, homocystinuria is caused by variants in a different gene, cystathionine beta synthase, CBS. To read more about homocystinuria caused by CBS deficiency, please. Diagnosis. A blood test that measures total homocysteine levels can diagnose hyperhomocysteinemia. Genetic testing of the MTHFR gene may be used to confirm the diagnosis of an inherited hyperhomocysteinemia caused by MTHFR deficiency. However, a 2013 practice guideline from the American College of Medical Genetics and Genomics, ACMG, states that there is growing evidence that MTHFR polymorphism testing has minimal clinical utility and, therefore, should not be ordered as a part of a routine evaluation for thrombophilia. In an infant or child in whom autosomal recessive severe MTHFR deficiency is suspected, tests for plasma homocysteine and serum amino acids levels would be expected to show a pattern of extremely elevated homocysteine and low methionine. MTHFR full gene sequencing, as opposed to targeted polymorphism testing, can confirm the suspected clinical diagnosis. Management. 2013 statement from the American College of Medical Genetics and Genomics, ACMG, includes the following recommendations. MTHFR polymorphism genotyping should not be ordered as part of the clinical evaluation for thrombophilia or recurrent pregnancy loss. MTHFR polymorphism genotyping should not be ordered for at-risk family members. A clinical geneticist who serves as a consultant for a patient in whom an MTHFR polymorphism, S, is found should ensure that the patient has received a thorough and appropriate evaluation for his or her symptoms. If the patient is homozygous for the thermolabel variant C.665 CT, the geneticist may order a fasting total plasma homocysteine, if not previously ordered, to provide more accurate counseling. MTHFR status does not change the recommendation that women of childbearing age should take the standard dose of folic acid supplementation to reduce the risk of neural tube defects as per the general population guidelines. Organ meats, nuts, beans, nutritional yeast, and raw/fermented dairy products. Genetic testing. The NIH Genetic Testing Registry, GTR, displays genetic tests that are currently available for the MTHFR gene and for homocysteinemia due to MTHFR deficiency. Biochemical genetic tests may also be used, which assess the level of activity of the MTHFR enzyme or the level of analyte in the blood. GTR provides a list of biochemical tests that assess the level of homocysteine analytes and the activity of the MTHFR enzyme. Genetic counseling. The MTHFR polymorphism has been associated with many different medical complications. Individuals who are MTHFR positive carry 1 or 2 copies of variants in the MTHFR gene. However, in general, the following genotypes are unlikely to be of clinical significance. 677 CT heterozygote. C.1286AC homozygote. 677 CT, C.1286AC, compound heterozygote. Individuals who are TT homozygous with normal homocysteine levels do not have an increased risk of venous thrombosis or recurrent pregnancy loss, according to recent evidence. However, women do have a modestly increased risk of having a child with a neural tube defect, and this risk increases if the fetus is also homozygous. If homocysteine levels are elevated, TT homozygotes may have a mildly increased risk of venous thrombosis or recurrent pregnancy loss, but not other previously associated conditions, such as cardiovascular disease. Less is known about the C.1286AC variant, but current evidence suggests that it is milder than the thermolabel C.665 CT variant. We found that presence of rare allele C in heterozygous and rare homozygous genotypes significantly increased the risk of RPL. No significant change in the fetal MTHFR A1298C genotype frequency was observed, regardless of chromosomal integrity. Meta-analysis of A1298C polymorphism on both RPL and in spontaneously aborted embryos showed significantly increased risk in the carriers of AC and CC genotypes. Conclusion: the data of the present study clearly suggests that MTHFR A1298C polymorphism is a genetic risk factor for pregnancy loss. For all individuals, it is important to determine whether medical disorders have been incorrectly attributed to their positive MTHFR status. Referral to a hematologist or maternal fetal medicine specialist may be needed. And patients should provide their MTHFR genotype status to their physician before starting chemotherapy agents that require folate, e.g., methotrexate. Finally, MTHFR positive individuals may decide to take vitamin B and folic acid supplements. Although safe, toxicity is rare. Evidence is lacking on whether such supplements reduce the risks associated with hyperhomocysteinemia or MTHFR genotype status. Because the current evidence so loosely supported, there are many scientists who challenge the notion that miscarriages and the MTHFR mutation are somehow linked. Those who support the hypothesis do so based on the increased incidence of miscarriage among women with a specific variant known as the MTHFR C677T mutation. Key to the argument is the role that homocysteine is believed to play. Homocysteine is amino acid naturally produced by the body that aids in the metabolism of B vitamins. In the presence of the C677T mutation, homocysteine cannot be effectively recycled and begins to accumulate in the blood. When this happens, it can lead to an inflammatory condition called homocysteinemia, which is a known risk factor for coronary artery disease. Those who support the theory have suggested that homocysteinemia may cause the formation of tiny blood clots which block the flow of nutrition to the placenta, essentially starving the fetus and triggering a spontaneous abortion. It's a highly contentious theory and one for which there really isn't any hard evidence. With that being said, many women with recurrent miscarriage will test positive for the MTHFR mutation. As such, some doctors have endorsed the use of anti-clotting drugs such as heparin and low-dose aspirin to reduce the risk of blood clots. Others recommend high doses of folic acid and other B vitamins, believing that may provide homocysteine a target and route by which to be eliminated from the body. While there is no proof that any of these measures will reduce the risk of miscarriage, there is also little evidence to suggest that will do any harm. Management. In common forms of MTHFR deficiency, elevated plasma homocysteine levels have sometimes been treated with vitamin B12 and low doses of folic acid. Although this treatment significantly decreases the serum levels of homocysteine, this treatment is not thought to improve health outcomes. Due to the ineffectiveness of these treatments, it is no longer considered clinically useful to test for MTHFR in most cases of thrombophilia or recurrent pregnancy loss. Prognosis. Whether MTHFR deficiency has any effect at all on all-cause mortality is unclear. One Dutch study showed that the MTHFR mutation was more prevalent in younger individuals, 36% relative to 30%, and found that elderly men with MTHFR had an elevated mortality rate, attributable to cancer. Among women, however, no difference in life expectancy was seen. More recently, however, a meta-analysis has shown that overall cancer rates are barely increased with an odds ratio of 1.07, which suggests that an impact on mortality from cancer is small or zero.